Hello, I'm Dr. Emily Carter, a medical doctor focused on providing thoughtful, evidence based care and supporting patients in achieving better health outcomes. There is a shape, one specific shape, that if you have been seeing it in the toilet for the last few weeks and dismissing it as nothing, may be the most important detail I tell you today. It doesn't hurt, it doesn't bleed, it doesn't announce itself with pain or fever or anything you'd normally associate with something serious. It just keeps appearing quietly day after day. And most people who notice it decide it's probably related to something they ate and they move on. Some of them are right, some of them are not. I've been practicing medicine for 12 years and I work almost exclusively with adults over 60. I've sat across from patients who came in for something routine, blood pressure, a follow-up, a prescription renewal, and mentioned almost in passing that they'd been noticing something in the bathroom for a while but weren't sure it was worth bringing up. And I've had to look at them and say, that was worth bringing up. That was the thing to bring in much sooner. Not because I was trying to alarm them, because it was true. Here is what I've come to understand. The digestive system leaves you a physical record of what's happening inside your body every single morning. Color, consistency, shape, each one carries information. And some of that information is specific enough that a physician can use it to find something that hasn't yet produced a single symptom anywhere else. The problem is that almost no one has ever been taught how to read it. The conversation doesn't happen in the average clinic visit. There isn't time, or it feels like an uncomfortable subject, or the doctor assumes you already know. And so decades pass and people flush that record away every morning without glancing at it, not out of carelessness, but because no one told them it was worth reading. That ends today. What I'm going to walk you through in the next 20 minutes is what your body has been trying to tell you through that daily record. What normal actually looks like, what the common departures from it mean, which colors demand attention and which ones don't, and which shapes, when persistent, should send you to a physician without delay. By the time this video is over, you will have a framework that most people spend an entire lifetime without. I want you to stay until the end because the most important part, the sign that I consider the most frequently missed and the most frequently misunderstood, I'm saving for the section that changes this conversation entirely. I'm Dr. Emily Carter. I specialize in adults over 60, and the question that has guided most of my clinical thinking for over a decade is a quiet one. What is the body already trying to say? Not the dramatic signs that send people to the emergency room. Those tend to take care of themselves. The quiet ones, the ones that arrive weeks or months before anyone starts paying attention. If this is your first time on the channel, I'd invite you to subscribe. I post every week, and I don't rush through subjects that deserve more than a surface explanation. This is one of them. Before we can talk about what's wrong, we need to establish what's right. Because you can't recognize a departure from normal if you've never been told what normal actually looks like. And when it comes to this particular subject, most people genuinely have no baseline. What you want to see on most days is something that looks roughly like a sausage or a smooth, slightly curved log. Soft, but formed. Not watery, not crumbly, not compact to the point of being difficult. Something that passed without significant effort, without discomfort, without leaving you with the uncomfortable sense that the job isn't quite done. And it should be brown. That brown is not incidental. It has a specific origin. Your liver produces a fluid called bile, which gets stored in the gallbladder and released into the small intestine whenever you eat something that contains fat. Bile's job is to help break fat down so the intestinal wall can absorb it. And bile at the source is green. Genuinely, distinctly green. Not a pale or muted green, but a real one. The kind that looks nothing like what you'd expect from something the body makes. If you could see it where it's first produced, it would look out of place next to any food on a plate, but it travels. It moves through the entire length of the digestive tract, a distance that is longer than most people realize. Bacteria act on it along the way. Enzymes continue working. Chemistry shifts in ways that are quite involved, but the result of all of it, when the transit goes as it should, when the bacteria are doing their part, when nothing is rushing things or slowing them down unreasonably, is brown. The color we recognize, the color that tells you the system completed its work. Soft, formed, brown, passed without straining. That is your baseline. Keep it in mind because everything else I'll describe today is a departure from it in one direction or another. The first thing most people notice when something seems off is consistency, how hard or how loose. And the two extremes tell genuinely different stories. Hard, dry stool that breaks into small pellets, sometimes described as pebbles, or the kind of pellets a rabbit leaves, usually means that material spent too long inside the colon before it was passed. One of the colon's jobs is to absorb water from what moves through it. That's a normal and necessary function. But when transit is slow, when things stop moving at a reasonable pace, the colon keeps doing that job past the point that's helpful. It keeps pulling moisture out. What was once soft and manageable becomes dry, compact, and resistant. This is what constipation is mechanically, and the word doesn't fully capture what's actually happening. It can come from dehydration, which is both common after 60 and often underestimated. Many of my patients drink far less water than they realize, partly because the sensation of thirst becomes less reliable with age. Thirst is an imperfect signal in younger people. It becomes an even less reliable one later. Low fiber intake plays a role too, as does a category of medications that slow gut motility, including certain blood pressure drugs, some pain medications, and iron supplements. And there's something called diverticular disease, where small pouches form in the colon wall over years of inadequate fiber, sometimes trapping material and disrupting the smooth movement of everything else. What most people don't realize is that hard, pellet-like stool is not just uncomfortable. Over time, straining to pass it creates pressure in the colon and pelvic floor that has its own set of consequences: worsening hemorrhoids, weakening of the pelvic floor muscles, and small tears in the tissue around the exit that then make the next bowel movement even more difficult. It's a cycle that builds on itself. On the other end is diarrhea. And here I want to be precise, because there are two versions of this that people routinely treat as the same thing when they are not. Loose stool for a day or two after a difficult meal, a course of antibiotics, a stomach virus, or something that simply didn't agree with you. That is your gut reacting to a specific disruption and correcting itself. The body has systems for this, and they work reasonably well. Rest, fluids, some time. Most of the time it resolves. Diarrhea that persists for more than 4 weeks is a different situation entirely. That's not the body adjusting, that's the body failing to return to baseline. And the reasons behind it can range from chronic inflammation of the intestinal lining to a parasitic infection that the immune system hasn't cleared to, in some cases, a tumor somewhere along the intestinal tract that is irritating the tissue and disrupting the normal rhythm of movement. None of those possibilities improve on their own if you wait long enough. If loose stool has been part of your daily life for a month, the answer is not a different probiotic. The answer is a physician who can investigate what hasn't resolved. Color is where the digestive system leaves some of its clearest records, and it's also where most people have no framework at all. Green stool is probably the color people worry about most when they shouldn't. A diet rich in leafy vegetables, spinach, kale, broccoli, anything deeply green can push the color in that direction without any deeper meaning. The chlorophyll is simply present in enough quantity to influence what comes out. Green stool can also happen when food moves through the intestinal tract unusually fast, not giving bile the time it needs to complete its transformation from green to brown. The journey gets cut short, the color stays. This isn't dangerous on its own, but if it keeps happening without a clear dietary explanation, it's worth mentioning to your doctor because it may indicate that your gut is moving things faster than it should. Pale stool is more clinically significant. clay-colored, yellowish, almost chalky in some cases, with very little of the brown we're looking for. When stool lacks that color, it usually means the bile didn't arrive in adequate quantity or wasn't produced properly to begin with. Brown comes from bile. If the bile isn't there or isn't reaching the intestine in normal amounts, the stool reflects that absence. The causes of this range from blockage in the bile duct to liver dysfunction to problems with the pancreas, which plays a role in fat digestion and works closely with the bile system. A parasitic infection called Giardia can also produce exactly this kind of pale, greasy, foul-smelling stool. None of these situations resolve reliably on their own, and none of them should be explained away as something dietary. There's also a fatty, greasy quality that sometimes accompanies pale stool that seems oily or that leaves an oily ring in the bowl. This is called steatorrhea, and it means fat isn't being absorbed properly. Fat that should have been broken down and taken up by the intestinal wall is instead passing through. That can come from the pancreas not producing enough digestive enzymes, from bile insufficiency, or from conditions affecting the intestinal lining itself. It's not a dramatic symptom. Most people notice it briefly and move on, but it's a meaningful signal about fat digestion that deserves investigation. And then there are two colors that should cut through whatever hesitation you might have about picking up the phone. Black stool, not dark brown, which is common and usually unremarkable. Black, the color of tar, sometimes with a consistency that approaches it. Thick, almost sticky, and a smell that is notably stronger and different from anything you describe as normal. What you're seeing when stool looks like that is blood that has been digested. When blood enters the upper portion of the digestive system, the esophagus, the stomach, the first part of the small intestine, it travels the entire length of the tract along with everything else. By the time it exits, it no longer looks like blood. It has been processed into something dark, thick, and unmistakable. The causes include bleeding peptic ulcers, severe gastritis, and something called esophageal varices, dilated blood vessels in the esophagus that can rupture, often in association with liver disease. Any of these is a medical emergency, not a situation for monitoring, not something to assign to the iron supplement you started recently. Although iron can darken stool, it doesn't produce the tar-like appearance and smell I'm describing. If what you're seeing is black and tar-like, you need to be evaluated that day. And bright red blood visible in the toilet, coating the outside of the stool, or present on the toilet paper. This is bleeding from the lower end of the digestive tract, the sigmoid colon, the rectum, or the area just inside the exit. Because the blood hasn't traveled far, it hasn't been processed. It arrives red. Hemorrhoids are a common and benign source of this. I want to be fair about that because hemorrhoids affect a large proportion of adults over 60, and most of the time when there is visible red blood, hemorrhoids are what's behind it. But I'll be direct with you. Hemorrhoids are also the assumption most people make when they shouldn't make any assumption at all. Polyps bleed, colorectal cancer bleeds, and the reason both of those can go undetected for months or longer is that people see red blood. They remember they've had hemorrhoids before, and they file the symptom under something they already know. I have seen this pattern more times than I would like. Bright red blood needs to be seen by someone who can actually look at the source, not diagnosed by process of elimination from the outside. I want to slow down here for a moment. My father was not a man who used more words than he needed. He had grown up in Beirut in a household where speech was deliberate, where you thought before you spoke, where you named only what you were certain of. He carried that into how he moved through the world, and he passed some of it on to me. In medicine more than anywhere else, be specific, be accurate. Don't name what you haven't examined. I go through all of this not to frighten you. I want to be honest with you about that. What I'm trying to do is give you the names for things so that if you encounter them, you can recognize them and act on them, not react to them with panic. Recognize them with the calm that comes from knowing what you're looking at. Now, I want to come to what I consider the most important part of everything I'm going to say today. Not color, not consistency, shape. Specifically, stool that is thin, narrow, flat. Sometimes people describe it as ribbon-like, sometimes as narrow as a pencil or a finger or a crayon. Stool that has changed in width from what it used to be, and that has held that change. Not once, not on one unusual morning, but consistently, day after day, week after week. This is the sign that I see most often missed. Not because people don't notice it, sometimes they do, but because they don't know what to do with it. It doesn't look dramatic. It doesn't hurt, usually. It doesn't bleed. And so, it gets filed away. I need you to understand something about the anatomy here because it makes everything else make sense. The colon is a tube, a physical tube, roughly 5 feet long, looping through your abdomen in a specific path before ending in the rectum and the anal canal. The interior diameter of a healthy colon is generous enough that what passes through it takes on a full, rounded shape. The tube shapes what moves through it the way any hollow channel does. When something changes the inside of that tube, when something presses on it from the outside or grows inside its wall or narrows its lumen, what passes through narrows with it. Stool exits looking different because something has changed the space it moves through. Pencil-thin stool that keeps happening is the body telling you something has changed in the shape of that tube. There are benign explanations. A chronic anal fissure, a tear in the delicate tissue at the very end of the canal, can create scarring that narrows the exit. Diverticular disease can sometimes affect the shape of what passes through. External pressure from the outside, including from structures near the colon, can occasionally be a factor. These are real possibilities, and a physician will consider all of them. But persistent pencil-thin stool is also one of the recognized early presentations of colorectal cancer. I use the word early deliberately, and I want you to hear that word clearly. This shape change often appears before pain develops, before weight loss, before anything that most people associate with a serious diagnosis. The body is giving you this sign while the window for intervention is still wide open. While the situation is still manageable, I want you to understand the weight of that. If you have been noticing this, and if the width of your stool has changed and kept changing, if you've been quietly tracking it and telling yourself it will pass, please let a physician determine what it probably is. Not a search engine, not a best guess. A physician who can examine you and, if necessary, look inside. What I've come to see over years of practice is that these signs rarely arrive alone. The body tends to send things in clusters, and when there is a structural change in the colon, when something is narrowing that tube, other signals usually travel alongside it. You might notice a persistent sensation of needing to have a bowel movement even when very little comes out or nothing does. A sense of pressure that doesn't resolve, of incompleteness, as if the bowel hasn't quite finished. Clinicians refer to this as tenesmus. It can feel similar to constipation, but it doesn't respond to the usual adjustments: more fiber, more water, more movement. The sensation keeps returning because it isn't caused by what you ate. It's caused by something physical inside the rectum or lower colon that the body is registering as presence. You might notice fatigue that is different from tiredness, not the kind that improves after a full night of sleep, a heavier kind, one that has settled in without a clear reason and doesn't lift the way it should. When the body loses blood slowly, in amounts too small to see in the bowel, over weeks and months, anemia develops. The red blood cell count drops gradually. The body compensates for a while, as it often does, before the compensation stops being enough. And when it stops, the fatigue that emerges is distinctive, flat, persistent, not addressed by rest, pallor, looking different to the people who know your face, appearing paler, less vital, someone close to you saying something about the color of your complexion and not being sure how to put it, abdominal cramping that keeps coming back to the same location rather than moving around and fading the way ordinary gas or indigestion does, a dull ache with a fixed address, weight that you haven't tried to lose, dropping without explanation, not a few pounds from eating less, a gradual, unexplained reduction that no one in your house can account for. None of these symptoms alone names a diagnosis. I want to be careful about that because each one of them has a long list of possible causes, most of them far less serious than what I've been describing. But when several arrive together, particularly alongside a change in stool shape, persistent blood, or both, the combination asks for attention. The body doesn't usually send everything at once. It accumulates quietly, one signal at a time, and waits to see if you're paying attention. Let me be specific about when I want you to stop waiting. Black tarry stool, even once. That is not a situation for watching another day or two to see if it continues. It's a same-day call to your doctor or a same-day visit to an emergency setting. Bright red blood that you cannot confidently attribute to a confirmed currently active hemorrhoid. Even if you've had hemorrhoids before, if the blood is new or heavier than before or different in any way, don't assign it. Have someone look. Stool that has been consistently narrow or ribbon-shaped for more than 2 or 3 weeks, particularly if you are also noticing any of the accompanying symptoms I described. 2 or 3 weeks is not a long time. If it has been that long, that pattern has earned a conversation with a physician. For any of these, the appropriate step is a physician who can refer you to a gastroenterologist or colorectal specialist. In many cases, a colonoscopy will be part of what follows. I want to say something about colonoscopies because I've watched people postpone them for years based on discomfort with the idea, and by the time they finally came in, the conversation was different from what it would have been. A colonoscopy is the procedure that lets a physician see the inside of that tube directly, not infer it from the outside, not estimate it from an image, actually see it. And when the scope finds a polyp, and it often does in adults over 60 because polyps are common, it can usually remove it during that same examination. A polyp removed before it transforms is not a cancer story, it's a prevention story. Those are completely different outcomes. One of them comes from having looked when the signs suggested looking was warranted. After 60, a colonoscopy is not the frightening thing the reputation suggests. The preparation is inconvenient. The procedure itself is done under sedation, and patients generally remember very little of it. What it offers in return is information, actual information about what is inside, not an educated guess from the outside. In the face of the signs I've described today, that information is not optional. Waiting for more certainty before agreeing to look is precisely how certainty becomes harder to come by. Before I close, I want to connect something that I think is important. We talked today about pale clay-colored stool, and I explained that the brown we're looking for comes from bile, and that bile originates in the liver. When the liver is under stress, when it's working through something it has accumulated over time, bile production changes. The quality and quantity of bile being released into the small intestine is affected. And when the bile changes, the stool reflects that change. The pale or chalky stool I described as a warning sign today is, in many cases, a downstream effect of what is happening upstream in the liver. The previous video on this channel was about exactly that system, about the fatty liver, what accumulates inside it over years and decades, and about a specific bitter compound found in certain plants that has been observed to support the liver's clearing and regenerative function. If what I described today about pale stool, disrupted bile flow, or the liver's role in digestion caught your attention, that video belongs alongside this one. The connection between what you see in the bowl and what is happening in your liver is closer and more direct than most people have ever been told. The link is below this video. And I'll leave you with this. The bathroom gives you a physical record of what happened inside your body. Every single day, most of those days, the record will show you that your digestive system is doing its work quietly and well. Most of the time, you'll see exactly what you'd hope to see, and you'll flush, and you'll move on. But on the days when something is different, a color you haven't seen before, a shape that has changed and stayed changed, blood where there was no blood before, you now have a way to understand what you're looking at. You know the signs that are worth noting. You know the ones that should not wait. And you know the difference between a body that is adjusting and a body that is asking for your attention. Your body has been leaving you these records for years. Today, you learned how to read them. I'm Dr. Emily Carterl. I'll see you in the next one.